Hello, and welcome to Chapter 3. Here we will be describing core elements, or effective ingredients, of evidence-informed interventions. By the end of this session, you should be able to define core features of evidence-informed interventions, assess evidence-informing interventions, and identify irrelevant, ineffective, or outmoded interventions for de-implementation. Let's start by defining core elements of evidence-informed interventions. Evidence-informed interventions, or EIIs, represent science-based tools that have demonstrated efficacy in enhancing the health outcomes of populations. These interventions are commonly referred to as evidence-based practice or evidence-based public health. It's essential to recognize the diverse forms of evidence that underpin these interventions. Traditionally, evidence has been derived from large-scale population-based randomized controlled trials, which serve as crucial tests of efficacy and cost-effectiveness. Such trials are conducted under controlled conditions, with well-defined measurable objectives. While this approach is valuable for guiding clinical practice, it often prioritizes objective, measurable, and controllable metrics, overlooking contextual nuances and individual experiences. Implementation science advocates for a broader perspective on evidence, one that is adaptable to real-world practice scenarios and acknowledges the cultural and psychosocial context. This approach entails describing core intervention components and their relationships with various settings, audiences, and approaches, thereby offering a more comprehensive understanding of how interventions function within diverse contexts. The terms informed and practice are used to underscore that public health decisions are shaped, not only by research findings, but also by insights gleaned from frontline practitioners and the lived experiences of patients and community members. In this context, evidence-informed interventions encompass a wide array of initiatives, including programs, practices, processes, policies, and guidelines, all supported by varying degrees of evidence of effectiveness across diverse community settings. Of particular relevance to implementation science, evidence-informed interventions represent a multi-level process that entails gathering and applying the best available evidence from research findings, practical experiences, professional insights, and input from clinical or community partners. This holistic approach acknowledges the importance of integrating various sources of evidence and expertise to inform decision-making and optimize the implementation of interventions. It's crucial to emphasize that for successful implementation, evidence-informed interventions must incorporate core elements. These core elements serve as guiding principles for selecting interventions tailored to a specific target population, by highlighting essential features such as the required skill sets, necessary activities, and cultural considerations addressed in the intervention sessions. Intervention core elements, also referred to as active ingredients, are critical program components deemed necessary for intervention effectiveness. Describing these core elements to implementers in a clear manner supports fidelity and ensures they comprehend the impact of these elements on behavioral and health outcomes. Moreover, core elements play a vital role in adaptation, by delineating boundaries between programmatic activities that should remain unchanged and those that can be modified without compromising intervention fidelity. Additionally, core elements serve as the foundation for quality assurance efforts, as they enable monitoring of fidelity during intervention implementation. This ensures that elements critical to the intervention's success are upheld, thereby enhancing the overall effectiveness of the intervention. In the realm of clinical interventions, such as those aimed at preventing or treating diseases or improving clinical symptoms like medications, vaccines, or specific technologies, the core elements are often straightforward. These elements typically encompass the specific drugs, vaccines, or technologies required, which are both necessary and sufficient for the treatment to be effective. However, for interventions targeting behavioral change to improve health, the core elements may be less obvious. In such cases, identifying the core elements of evidence-informed interventions can be approached in three systematic ways. These approaches include program practice. drawing insights from the routine delivery of services to discern core elements. Behavioral theory, applying predetermined constructs from behavioral theories to identify essential intervention components. And systematic research, utilizing findings from scientifically conducted studies to pinpoint core elements. Expanding on this approach, qualitative research could be employed to gather perspectives from end users and directly observe intervention implementation, further enriching the understanding of what constitutes core elements in behavioral change interventions. Galbraith and colleagues propose a taxonomy designed to facilitate the identification of core elements within evidence-informed interventions, using categories organized into three overarching domains: content, implementation or delivery, and the pedagogy used. Within the implementation domain, core elements encompass practical features or logistical aspects of intervention delivery that are instrumental in enabling the program to be effectively implemented. The content domain pertains to the substance of what is being taught through the intervention, aligning closely with models and theories of behavior change. Finally, the pedagogy domain encompasses core elements related to how the intervention content is taught or delivered, including the engagement style utilized to convey the content effectively. Let's now delve into a case study that applies the core elements taxonomy to the Nutrition Education Program, NEP, designed for adults with type 2 diabetes, across primary to tertiary healthcare settings, in South Africa. Diabetes self-management education, which includes nutrition education, has been widely recognized for its ability to enhance behavior mediators, foster self-care practices, improve glycemic control, and yield positive health outcomes. However, to fully benefit from educational interventions, structured delivery is essential. Utilizing established programs with proven effectiveness not only saves time and resources, but also enhances the likelihood of achieving successful outcomes. Nonetheless, adapting an existing intervention from one setting or population group to another often necessitates adjustments to suit the specific needs of the new population. In their study, researchers assessed the applicability of the NEP in this new setting, focusing on the identification and evaluation of the intervention's core elements. 6 elements believed to contribute to the success of the original NEP were identified. These elements likely played a role in promoting positive dietary behaviors by enhancing behavior mediators, such as self-efficacy, knowledge, skills, and outcome expectations. The identified core elements include group delivery format, face-to-face delivery supplemented with educational materials, such as posters, hands-on activities and demonstrations, cultural appropriateness of the NEP, follow-up interventions, and the use of multiple behavioral change techniques proven effective in altering dietary behavior. All of these core elements align with the 3 main taxonomy classifications: implementation, content, and pedagogy. In this section, we have looked at evidence-informed interventions as science-based tools, with proven efficacy and effectiveness, and at how Galbraith's proposed taxonomy is useful for identifying core elements of evidence-informed interventions. In this next section, let's assess the types of evidence which should inform health interventions by conducting a comprehensive examination of the various types of evidence. Evidence is central to implementation science. Both dissemination and implementation efforts hinge on the premise that certain practices and policies, supported by scientific research, should be widely adopted due to their potential widespread benefits. Evidence within the realm of public health comes in many different forms spanning 3 broad domains. Type 1 evidence focuses on understanding the causes and burdens of health issues. Type 2 evidence centers on assessing the effectiveness of interventions in addressing these health issues. Type 3 evidence examines the processes and outcomes of implementing interventions within specific contexts. These 3 types of evidence are not typically linear but rather interconnected, iterative, and often overlapping, influencing one another's development and interpretation. For instance, limitations in Type 2 evidence can hinder the application of Type 3 evidence. Among these domains, Type 1 evidence tends to be the most abundant, while Type 3 evidence is relatively scarce. Definitions of evidence and the methodologies for its utilization vary across different settings. Fundamental issues central to implementation science involve these questions. What evidence is available and for whom is it relevant? In which settings is the evidence applicable, and under what conditions? At what point do we possess sufficient evidence for dissemination and implementation? How do contextual factors, health equity considerations, policy implementation strategies, and stakeholder perspectives inform the determination of the evidence base? These fundamental inquiries underscore the complexities inherent in leveraging evidence to inform effective implementation strategies, and highlight certain research or knowledge gaps within the realm of implementation science. Specifically, questions pertaining to context, equity, and stakeholder involvement shed light on aspects of implementation science that have often been overlooked and warrant further investigation. To foster the development and delivery of interventions that are more equitable and sustainable, scholars advocate for a broadening of perspectives on evidence, particularly concerning Type 3 evidence. Here are some suggested approaches to expanding the evidence base regarding study designs, methodologies, strategies, stakeholder engagement, and outcomes. Randomized Controlled Efficacy Trial, RCTs. These trials are designed to control for various potential confounding factors, and are typically regarded as the gold standard for obtaining evidence on internal validity and contributing to the determination of causality of a given intervention, practice, or treatment. RCTs have the advantage of potentially balancing both known and unknown confounders, particularly with large sample sizes. Despite the value and conceptual simplicity of the traditional efficacy RCT, its limitations have been noted. For instance, randomization may not always be feasible, cost-effective, or ethical, particularly for interventions where withholding the program from the community raises concerns. Similarly, in the case of policy interventions, randomizing the independent variable, otherwise known as the exposure, may not be feasible. For some settings and interventions, alternative and more rapid cycle and adaptive designs are needed. These may include quasi-experiments, observational trials, iterative assessments and actions, natural experiments, and mixed-method studies. In implementation science, an understanding is necessary of how interventions may interact with existing programs within a given environment, a concept often referred to as mosaic effectiveness. For instance, consider a study evaluating long-acting PrEP agents to demonstrate their non-inferiority compared to daily oral TDF-FTC. Mosaic effectiveness necessitates that such an intervention be delivered within a context where oral PrEP is already available. This is because its impact is best evaluated in a setting where both options are present, allowing for a comprehensive assessment of its potential contribution. In the realm of public health practice, particularly within low- and middle-income country contexts, the generalizability of an intervention's effectiveness across diverse populations and settings, referred to as external validity, is paramount. While systematic reviews and practice guidelines often focus on an intervention's average effectiveness, or internal validity, they commonly overlook specifying the conditions under which the program is effective or ineffective, such as specific settings, populations, or circumstances. For implementation science, evaluating whether an evidence-based practice is applicable to a particular setting or population entails considering numerous factors and nuances. In Section 2, we talked about different kinds of evidence and the limits of efficacy evidence. We also talked about the type of evidence that guides implementation science and how effectiveness evidence can help in low- and middle-income country situations. In Section 3, our last section in this chapter, we are going to focus on identifying interventions for de-implementation. In order to be equipped to conduct implementation correctly, evidence is needed about null interventions, de-implementation, and misimplementation. From null intervention results, we can identify which components of an evidence-informed intervention need to be refined, adapted, or reinvented. Data on null interventions also informs for whom, and under what conditions, an evidence-informed intervention or implementation strategy is evidence-based. Unlike implementation, de-implementation research focuses on discontinuing interventions that should no longer be used. Implementation science increasingly recognizes the importance of also understanding when and how it is appropriate to decrease or end interventions. De-implementation means stopping interventions that aren't effective or may be harmful. It's about abandoning practices that aren't proven to work or could cause harm. Misimplementation involves either stopping effective programs or continuing ineffective ones in public health settings. Recent evidence suggests that de-implementation, like implementation, happens gradually over time. De-adoption, similar to adoption, is a decision made during the de-implementation process. A key question in de-implementation is figuring out which interventions should be stopped. Criteria for de-implementation include: when interventions aren't effective or are harmful, when better options are available, or when the health issue isn't a concern anymore. De-implementation may be needed when interventions lack evidence or are harmful. Prior to the emphasis on using evidence-based interventions, many interventions were implemented without having assessed their effectiveness. These interventions were often introduced and continued based on persuasion, training, or tradition. Interventions often persist even when not supported by evidence of effectiveness or when harmful. A well-known example is the Drug Abuse Resistance Education (DARE) program, widely implemented in the 1980s and 1990s to reduce drug use among adolescents. Despite its widespread use, when evidence became a requirement for federal funding in the United States, the program failed to demonstrate effectiveness, even after revisions in 2003. When more effective or efficient interventions are available, it may be necessary to consider de-implementing existing interventions, even if they are evidence-based. This decision could be prompted by various factors, such as high costs, implementation difficulties, redundancy with existing services, or lower effectiveness compared to newer interventions. This situation often arises in the context of chronic issues. For instance, in the field of HIV prevention, evidence-based behavioral interventions were widely disseminated in the mid-2000s. However, with advancements in biomedical research, interventions like pre- and post-exposure prophylaxis, PrEP and PEP, have shown high efficacy. As a result, it has become more cost-effective to prioritize PrEP and PEP for individuals at the highest risk of HIV, rather than providing behavior change interventions to a broader population. De-implementation may also be necessary when the issue of concern dissipates. At times, public health or social service issues diminish, rendering interventions unnecessary, especially in contexts like specific infectious diseases or emergency preparedness and relief. A notable example of de-implementation efforts is the global campaign to eradicate polio. Following significant reductions in polio incidence, with only 37 cases reported from 3 countries in 2016, efforts to combat the disease have shifted towards de-implementation. Another contemporary example is the use of non-pharmaceutical interventions, such as social distancing and lockdowns, during the peak of the COVID-19 pandemic as part of emergency response measures. As vaccines have been introduced, and the spread of the SARS-CoV-2 virus has decreased in some countries, these non-pharmaceutical interventions are no longer being implemented. The success of de-implementation efforts can be gauged by various outcomes. For instance, in the realm of de-implementation, acceptability can serve as an indicator, measured by stakeholders' willingness to discontinue an intervention. Similarly, appropriateness assesses stakeholders' perception of whether the intervention aligns with the needs of the target population and the capabilities of service providers. The continued existence of programs like DARE may partly stem from both low acceptability, indicating a lack of agreement on the need for de-implementation, and a belief that there are no better alternatives available. And that's a wrap for Chapter 3. In this chapter we learnt that the core elements of an intervention are broadly categorized into 3 domains: content, pedagogy, and implementation. We also learnt that public health evidence comes in many forms, across 3 broad domains: Type 1, evidence on etiology and burden; Type 2, evidence on effectiveness of interventions; Type 3, evidence on implementation within context. Implementation science increasingly recognizes the importance of also understanding when it is appropriate to end the implementation of some interventions. That's it for this 3rd chapter, but before you go, take a moment to consolidate what you have learnt by putting it into practice. Download this chapter's supporting resource material and complete the activity there. Once you have completed the activity, please join us for Chapter 4, which will help you to understand and apply the concept of fidelity and adaptation to the conduct of implementation research in low and middle income countries. See you there.